Welcome to the Explainer. Now, if you're an anesthesia student, or really anyone working in critical care, you already know a fundamental truth of the OR. Paralyzing a patient? Well, that's actually the easy part. You just push that syringe of muscle relaxant and boom, it takes a few seconds. But knowing exactly when it's totally safe to pull that breathing tube without relying on just pure guesswork, that is a complex, literal, life-saving puzzle. So today, we're going to master the absolute best tool we have to solve that puzzle: Train of 4, or TOF monitoring.
We've got a really great roadmap ahead of us today. We're going to cover the paralyzed patient problem and TOF basics, setup in the FADE, decoding the metrics, the surgical timeline, and we'll wrap up with pitfalls and troubleshooting.
So let's kick things off with a million-dollar question. How do you actually know when it's safe to wake a paralyzed patient? You see, neuromuscular blocking agents, or NMBAs, have just incredibly unpredictable clinical durations. One patient might chew through a dose in 30 minutes, while another, they might take an hour and a half. Because of this massive, unpredictable variability, relying on time alone since your last dose is incredibly dangerous. We need hard, objective data.
All right, let's jump right into Section 1, the paralyzed patient problem and TOF basics. Enter our solution, the Train of 4. By definition, this is a specific pattern of electrical stimulation where we deliver exactly 4 distinct impulses to a peripheral nerve in really rapid succession. Since we obviously can't see the microscopic neuromuscular junction with our naked eyes, we use a peripheral nerve stimulator. We artificially stimulate a motor nerve, and then we just observe the response of the muscle it innervates. By analyzing that muscle's response, we can pinpoint the exact depth of the blockade.
Now, as an anesthesia provider, you absolutely have to know what your equipment is doing behind the scenes. The Train of 4 delivers a frequency of 2 Hz, meaning 2 stimuli per second. With an interval of 0.5 seconds between each stimulus, the entire burst is over in exactly 2 seconds. Quick and dirty. But notice that last point. The current is super maximal, usually sitting between 30 and 60 milliamps. Why so high, right? Well, because we have to make absolutely sure that every single nerve fiber within that bundle is depolarized, so we get a truly accurate read of the muscle's potential.
Moving right along to Section 2, setup and the FADE.
Look, proper monitor setup is non-negotiable. If you get this wrong, your data is garbage. Step 1, always clean the skin. You've got to wipe away those oils and dry the area to drop the electrical resistance. If your patient is cold and sweaty, that electrical current, it might not even penetrate down to the nerve. Step 2, place the negative electrode. That's the black one, distally. That means closer to the muscle you're monitoring. And step 3, the positive red electrode goes proximally right along the motor nerve path. In the OR, you're generally going to be choosing between 2 main monitoring sites, the ulnar nerve and the facial nerve. And they serve entirely different clinical purposes. The facial nerve, which you monitor at the jawline, makes the brow furrow. Why use it? Because facial muscles actually mimic the blood flow and the onset time of the diaphragm and vocal cords. It tells you the exact moment it's safe to drop in the breathing tube. But the ulnar nerve, monitored at the wrist, makes the thumb adduct. This muscle is literally one of the absolute last to recover from paralytics. Because of that, the ulnar nerve is the gold standard for judging safe airway recovery. Basically, if the thumb is fully back, you know the diaphragm is fully back. Okay, so what's actually happening down at the cellular level when we run a TOF? Let's talk about FADE. Think of the neuromuscular junction like the front lines of a battlefield. Non-depolarizing blockers, like rocuronium, they don't just block the postsynaptic receptors on the muscle side, they also block the presynaptic receptors on the nerve side. This effectively traps the nerve, preventing it from rapidly mobilizing fresh acetylcholine vesicles to the front lines. So when you shock that nerve 4 rapid times in 2 seconds, it instantly depletes its immediately available acetylcholine. And because the drug is blocking new acetylcholine from moving up as reinforcements, each of those 4 twitches gets progressively weaker and weaker. That progressive weakening from twitch 1 to twitch 4, that is the FADE. Keep in mind though, depolarizing blockers like succinylcholine don't cause FADE in their standard phase. Those twitches just decrease uniformly all at once. All right, let's break down the numbers in Section 3, decoding the TOF metrics. So our very first metric is the Train of 4 count. This is literally just you counting the visible or palpable twitches from 0 to 4. Now, as the block gets deeper, twitches actually disappear in reverse order, meaning twitch 4 goes away first, then 3, then 2, then 1. Let's look at the stages. At 0 out of 4 twitches, you've got a profound 100% receptor blockade. You're completely ready for intubation. At 1 or 2 twitches, you're in a deep to moderate block, which is perfectly sufficient for maintaining most regular surgeries. But once you hit 3 twitches, that block is getting light. And trust me, your surgeon might start complaining about muscle tightness.
And finally, when all 4 twitches are back, the receptor blockade has dropped below 75%, and you are firmly in the recovery phase, which requires reversal. But here's the catch. Once all 4 twitches are back, visual counting becomes completely useless. You just can't eyeball it anymore. It's impossible. So at this crucial point, we have to shift over to the train of 4 ratio. This is where you absolutely need a quantitative monitor, like an acceleromeograph, to do the heavy math for us. It calculates the exact ratio, taking the amplitude or the physical strength of that 4th twitch and dividing it by the strength of the first twitch, T4 divided by T1. If that ratio spits out less than 0.4, the patient is in a highly, highly dangerous state. Below 0.4, the patient feels incredibly weak, they're probably terrified, and they literally cannot even lift their own head off the bed. This is the number we're waiting for, a train of 4 ratio of greater than or equal to 0.90. This is it, the life-saving gold standard threshold. When you see 90% recovery of that 4th twitch compared to the first, you know definitively that pharyngeal tone and vital airway reflexes are fully back online. That is when it is absolutely safe to extubate. Section 4, the surgical timeline. Let's put this into practice. Let's walk through a real-world case timeline. At minute 0, your patient is asleep, but they're not yet paralyzed. You run a baseline TOF just to ensure your current is set right, and you can see what their normal twitch looks like. Boom, minute 3, you've pushed your NMBA. You're monitoring the facial nerve, and you're watching that count drop to 0. Once it hits 0, vocal cords are fully relaxed, and you intubate. By minute 60, we're in the maintenance phase. You've swapped over to the ulnar nerve, and you're titrating your drug doses to keep that twitch count hovering at exactly 1 or 2 so the patient doesn't move a muscle. Now it's minute 120, surgery is wrapping up. It's the reversal phase. You check the count. Remember, never ever give a standard reversal agent like neostigmine if the count is 0. You absolutely must wait for at least 2 twitches. Sure, Sugammadex is an exception, but even that requires exact TOF readings for the proper dosing. Finally, minute 135. The reversal's working. You switched your quantitative monitor. You literally sit there and watch that ratio climb until it hits 0.90 or higher. And only then, you pull a tube. Finally, Section 5, pitfalls and troubleshooting. All right, here are the absolute biggest traps you've got to watch out for. First up, direct muscle stimulation. If you accidentally place those pads directly over the muscle belly instead of following the nerve path, the electricity just bypasses the neuromuscular junction entirely. You're going to see the muscle twitch even if the patient is 100% paralyzed, so always place those electrodes carefully. Second, hypothermia. A cold arm literally means a cold nerve, and cold nerves conduct poorly, which is going to give you a falsely low ratio. Third, thick tissue from edema or adiposity. That extra tissue increases electrical resistance. The fix? You might just need to crank that current up to 60 or 80 milliamps. Or honestly, better yet, just switch your monitoring site up to the facial nerve where the tissue is a lot thinner. But honestly, the most dangerous pitfall of the whole bunch is what we call the tactile trap. Human senses are simply not sensitive enough to detect fade once the train of 4 ratio reaches about 0.4. If you're just resting your fingers on the patient's thumb, you might feel 4 strong twitches and assume, hey, they're fully recovered, when really they're sitting at a ratio of 0.6. If you extubate them then, they are at massive, massive risk for respiratory failure in the recovery room. Which leaves us with this final thought for you to carry into your next clinical rotation. If your fingers physically cannot feel the difference between paralyzing weakness and full airway recovery, isn't it time to just trust the math? Quantitative TOF monitoring isn't some optional fancy upgrade. It is the definitive modern standard for patient survival. Master the setup, truly understand the physiology of the fade, trust that 0.90 ratio, and you're going to navigate the paralyzed patient problem with total confidence. Thanks for joining me on this explainer, and keep learning out there.